Thank you, Dr. James Barone, for talking to us today about how to measure progress and competence in surgical trainees, medical students, and practicing surgeons. Can you give us some idea of how you think how if you think the current ways of measuring our progress and competence are effective ways?
Well, that is really an excellent question. As you know, it's being highly debated. And I think probably what we're doing could be improved a lot. Is the current way honestly any different than it's been for the last 40 or 50 years? I don't think so, because I know that I've actually been out of the business of training residents for more than 5 years, so I can't say what's going on right now. But I know that in the late last decade, while I was still involved, we did it the way we always did. We had a meeting. We talked about the residents. It was very subjective. The inter-rater reliability of the attending staff was highly variable, as you know. Perhaps you're laughing, so I think you agree with me. And the objectivity of it is extremely difficult because you have things like one bad episode with a resident, and then an attending really hates that guy for the rest of the 5 years of the training. And one person's perception of operative skill is different than another's, and these things are difficult. And the parameters that the RSC has set up are kind of nebulous, like professionalism, which to me is extremely difficult to define. And frankly, except for knowledge, which is the easiest by far of the competencies to measure, everything else is pretty much a very subjective and highly personal way of looking at people, and very difficult to quantify. And I was always when I was running residency programs, I was always in fear of somebody who had a negative review saying, well, what exactly have I been doing wrong? Because I would always have chats with everyone about their evaluations. And, you would say something like, well, so there's a feeling amongst some of the attendings that you're not very good at post-op care. And then the next question, like clockwork, is going to be, well, what exactly is it?
Right.
And you cannot pry that stuff out of your attendings, So I would have to say, yes, the assessment of competencies is really hard. And I don't think we do it very well. But I know you're going to ask me next, well, then how can we change it? And I'm not sure.
Actually, let me ask this.
Go ahead.
Take the one that we can fairly objectively measure, like a knowledge base. How much does having a strong knowledge base correlate with being a good surgeon?
Well, I would say not that much, honestly. Some of the worst surgeons that I ever knew were board certified. So, I think it's difficult to say because they could pass a test, a written test especially, but they couldn't take a living, breathing person and decide what to do with them. Or maybe they weren't so good in the OR, but they could pass a test. So that is, I would say, I don't know. There may be. See, again, it's hard to get something concrete about this, because I was going to say, well, there's probably a fairly weak correlation between knowledge and competency, but I don't even know if that's true. It may be a scattergram for all I know, and maybe it has no relationship. But I tend to think that smarter people, or people who do well on examinations, more of them will be good surgeons than people who do not do very well on exams. But
Sure.
Will they all? No, absolutely they will not.
Sure. Yeah, I was looking at what one of the residents was studying for their upcoming in-service exams the other day, and gastric hormones and some things that I thought, wow, this is a tremendous amount of time that this person's going to spend and that I spent learning things that really had very little correlation once you're out in practice.
Yes, I think honestly, if uh, if one were going to think about shortening medical school, for example, there are some places in that area in the basic sciences where, let's face it, we really don't use them, and I don't know really how important it is to know some of that stuff when you never use it at the bedside, and also the fact that you can find it in your phone. If you need to know the answer to the question, you can, do a search on the internet and find it. Makes you wonder what the value of that sort of thing is. And personally, I've always felt like we don't spend enough time teaching people how to think. And that goes, by that I mean, when you take the oral examination in surgery for the boards, the questions are pretty much all about what's your thought process on this, and how would you take care of this problem. It's not about what are the three branches of the celiac axis. It's about how do you take care of somebody with a gastric ulcer, and how do you work them up, and how do you do the surgery, and what are the complications that you might expect and look for. And we tend to emphasize on the tests the former, which is, name this, do this, what's the hormone that causes this to happen. And instead, I think we'd be better off with teaching and testing on the ability to think. And as far as I know, now I know there are OSCE exams, and lots of medical schools and some residencies are doing those kinds of practical tests. But when you're out as a surgeon, once you take the oral board exam, that, and pass it, of course, that doesn't come up again, does it, really?
Right.
And so the ability to think through a problem and tell someone what you would do is never tested once you get through the board exams. And so to me, that's more important than somebody who can memorize all the cranial nerves or the brachial plexus or other things that honestly don't come up that often.
So in other words, if I looked at all the tests that I took through medical school and surgery residency, I would definitely agree with you that the only one that I recall substantially measuring judgment and decision making was the oral boards. So do you think a lot of that other
yes,
stuff
and boy,
can and should be discarded and just move right early on?
Absolutely. And I agree 100%. And the time to realize that a person isn't very good at making thinking decisions is not the first time they take the oral boards.
When they're
that
done.
Wouldn't be a good time to that wouldn't be a good time to find that out, would it?
Right.
And now I know a lot of places, and I used to do this when I was running programs, and we did it every year. We had mock orals, and we would have people from other programs come, and you would be the local examiner, and then the guy from other place would be the other. But the problem with that always was that you got, once again, and highly variable questioners, unlike the actual board's oral exam, which I had the privilege of being a local examiner on once when it was held in a city not too far from where I live. It's pretty standardized, and of course the board examiners are very good at it because they've been doing a lot of it, and they tend to help you to not ask the wrong kinds of questions. And you have a book that has the standardized scenarios in it, and you can pick whatever questions you want. But when you have mock orals, you generally get a junior attending from someplace whose chief said, look, somebody's got to go down to Podunk here and give these guys a mock oral, so you're it. And the guy's like, I got stuff to do, I don't want to do this. And he's never done it before, and he's not very good at it. And then when somebody doesn't do well on that, Is it because they can't think very well and aren't very good at interpreting and synthesizing ideas, or is it this just that this was a horrible examination?
Yeah.
It
Yeah.
wasn't a very well standardized thing. So mock orals are probably better than not doing it, but I have known a couple of people to really be set back by them because the exam wasn't very fair
Yeah.
and wasn't not done very well.
Another thing that those mock orals revealed to me, when someone from another institution would examine our residents, it was interesting to see how much less bias they had. We'd have residents that we like, so we liked their answers. We had residents that were always having trouble, so their answers sounded a little more suspicious. But when you get someone from another institution going, that guy was totally off. it actually
Yeah.
helped to remove some of the bias that we had examining
Oh
our own
yes.
residents.
No, I agree, and as I said, it was better than nothing. But it's just unfortunate that we can't do it better
Sure.
and give them a more fair exam. And I actually videotaped them a few years, and I found that to be quite helpful, by the way, because the examinee often didn't realize that he was twitching or or sticking his finger in his ear or something while the test was going
Right.
on. And when they saw themselves completely flustered, it helped them to get a grasp on it, because you can tell them, hey, you looked like you were completely panicked. And they're like, okay, that's what you think. But then when you show them a thing and they look like literally deer in the headlights, it has a much more profound impression on the
Sure.
person. So I think there's plenty of value in doing it. It's just that it's hard to do it consistently well.
Sure.
And your other problem is your own attendings may not be very good at it either. They may think they
Right.
and you can't, as a program director, you're usually in a room doing it, and you can't go around and see what's going on, and you certainly can't say in front of the resident, hey, don't ask that question, it's not a fair question, or you're browbeating the guy, and that's not the way it is. In the old days, they did do that. The board examiners would really try to trick you and corner you, and now it's been changed to a more, I think, very much more reasonable examination, where it's not about tricking you. And if residents are going to watch this, I have to make sure they know that the oral board examinations are usually extremely straightforward. And you'd be amazed at how you can ask somebody a question about something simple like, how do you do a laparoscopic cholecystectomy? And a resident will start to tell you, and I don't know whether it's nerves or maybe they just don't know how to explain themselves, but they'll tell you the damnedest things. And you're like, we're not asking you about
It's not a trick question.
VIPomas here. Yeah, it's about gallbladder,
Yeah.
or an anal fissure. I mean, I would ask that question I actually asked that when I was doing the real oral board exam, because it was part of one of the scenarios, and some of the residents just didn't know what the heck I was talking about, and they couldn't answer one question about it. And then you really worry, because although nobody's going to be killed if somebody doesn't know how to take care of an anal fissure, it still makes you wonder about the whole training process, and if they can't even tell you what an anal fissure is or how you treat it. So the examination is very fair. Unfortunately difficult, though, to transpose into the residency situation where they're still in training, to do the same amount of fairness of an exam, and to have it fairly standard too, so that you can really compare one person's answers to someone else's. That's hard to do, and it gets back to the whole question of this topic: is how do you measure competence, and what are the ways to do it? And it is hard to do. I think it's very, very hard to do.
So moving to,
I will say, though, the one thing, though, that occurred to me just before talking, and I have never had this thought before, but all of a sudden it's interesting. I'm sure you're aware of a paper that came out in the New England Journal not too long ago by the guys from Michigan about the fact that bariatric surgeons, when you videotape actually videotape is not the right terminology anymore, there's no tape involved, but when you do videos of people's operations and then have people grade them, you can, it turns out that guys who aren't very good at bariatric surgery in the technical end have more
Worse
complications
outcomes. Yeah.
and worse outcomes. Yeah. So you could tape residents doing cases and get to the same place.
Yeah.
However, the problem, though, is that they aren't independently necessarily doing the case. And if they're being helped by an attending, he can guide them to not make a mistake. So even that is a little hard to assess. But it does bring up possibilities, especially for laparoscopic surgery, which is easier to make videos of than open surgery, which maybe with Google Glass, although I've seen a couple of surgeries recorded by Google Glass, and I have to say they're not as good as most videos because the guy who's wearing the glasses is moving his head around to, grab an instrument or look up at the monitor or, do something. And so it's kind of choppy and hard to follow.
Okay.
And I'm not sure it's the panacea for recording open operations that some people think it is, but that would be a way of at least perhaps assessing technical skill.
Sure.
Would be to do that, because I am not a fan of simulation in assessing skills. I think if you can move buttons from one glass jar to another, is not the same as doing an operation. Let's face it. And I know that the simulation people would argue up and down about it, and I respect that. I just don't believe it. And I think to do videos of operations might be very helpful in at least that part, assessing that part of competence, as long as you can separate the attending's role and make sure that you're assessing true competence of the residents. But the downside of that, by the way, and one of the things about the Michigan experiment was, and believe me, I think it was a great article, and it was really clever that they did it, and it was amazing that they got the results that they did, and it makes a lot of sense. However, it's a very time-intensive thing to have 10 different people rate even an edited operation, and somebody's got to edit the operations and all that too. So you're asking, it's a lot of time, which most people don't have to do it. It's hard to find time to do those kinds of things.
Right. Thanks again for your 2 cents.
It might be hard to do it in a training program too, especially if you had 8. Yeah. So.
Thanks again, Dr. Barone. We'll talk again soon.
You are welcome.
Bye-bye.
I hope so. Thanks. It's been fun.
Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook. Follow us on Twitter. And find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.